Welcome to Medical Myths, Legends, and Fairy Tales. I'm your host, Dr. Alan Christensen. Look, you know that between the latest online fads and the crazy media headlines, it's easier than ever to get confused about your health. And you and I just want to feel better and live longer. We want to know what works. And we can't wait for further studies. We need to make decisions today based on the best evidence we've got. Well, that's exactly what this show is here for. So let's get to it. I wanted to get one more angle on the topic of whether or not a low TSH is safe. I had a discussion with a patient advocate who has testimonials of people who feel better with low TSH levels. I had my own perspectives on how there has been research studies and also my own experience in patients to where there can be dangers from that. And I wanted to get the perspective of another clinician as well. This was Dr. Brittany Henderson. I had a really good time talking with her. She's written a good book that I enjoyed called What You Must Know About Hashimoto's Disease. Pretty unique. She's a conventionally trained endocrinologist and thyroidologist, not many of those out there. And now she has more of a integrative approach to her care. She really sees the value in lifestyle changes, diet, and she sees the shortcoming in diagnosis from the conventional side. But she's no stranger to the harm that can happen when patients are dosed incorrectly on thyroid medications. So Dr. Henderson and I had a really good discussion on this. I look forward to collaborating with her more in the future. So please enjoy the time with Dr. Brittany Henderson. Hey, Dr. C here with you. So this is really apropos. I've not done patient care for a bunch of years, but every so often I'll have a close friend that just asks me for some input on our situation. And about a week ago, a really, really dear friend has been struggling with some bad symptoms, really suppressed metabolism, sleep disturbances, a lot of changes with her energy levels. And she'd been on thyroid care, and she reached out to a mutual friend for some guidance. The mutual friend said, hey, I think you need to square away your thyroid. Just get some quick input from Alan here before moving forward. And it turned out she had had a really low TSH, and she had had that for decades. Now, I've covered this topic a little bit myself, and also I spoke with Janie Bothorpe from Stop the Thyroid Madness about this topic. And so I'm really jazzed to bring now Brittany Henderson here, Dr. Brittany Henderson, to talk with us about this one a bit further. So Dr. Henderson, welcome aboard.
Thank you so much for having me. I appreciate it.
So my friend, let's call her Cassie for anonymity. So she's got a super low TSH, and her doctor is trying to help her lose weight, and her doctor keeps raising her medication. Now, what she was told was that she had either pituitary disease or she had thyroid hormone resistance, because the doctor couldn't understand why her TSH would be low, why she could still be having a hard time losing weight, and why she didn't have an elevation of free hormones. So let's talk through a bunch of stuff, but just jump on in and give me your impressions about a situation like that.
Yeah, so I think the first thing is, talking about her TSH and what we think with regard to what is an optimal TSH level. TSH actually is not a thyroid hormone. It's a pituitary hormone. It stands for thyroid stimulating hormone. And it tells us, how well has her thyroid medicine been dosed over the last 4 to 6 weeks. When it's super high, it's hypothyroid, underactive. When it's super low, it's overactive or more hyperthyroid. And I always talk with my patients. I am a board certified endocrinologist. We were always taught, get it in the normal range. But normal range for a TSH is very controversial as well. So if you look at a reference range for a lab, you're going to find that a normal TSH can be anywhere between 0.5 to 5.5. And that's a really, really wide range. If you go back to some of the data like NHANES 3 and some of the data that followed that, people did repeat studies on the NHANES 3 data, which is what established that normal TSH reference range, and figured out that about 15 to 20% of that population had underlying Hashimoto's disease or autoimmune thyroid disease. And so when they reanalyzed what's a normal TSH, 0.5 to 2 came out as what's normal. And so that's usually where I try to optimize people's TSH. There's thoughts, in the functional medicine community, some practice providers, and even among patients, that having a very suppressed TSH level is not a problem. And just making sure that people feel good and they're losing weight and their T4 and their T3 look good is the most, important thing when you're looking at thyroid levels. But I always caution people that TSH is a hormone as well. It has to be optimized just like your free T4, just like your free T3. It has action in the body. So when you talk about your friend and the fact that she's been weight loss resistant, one of the actions for TSH, besides stimulating thyroid hormone production from the thyroid gland, is that it has actions actually in the fat cell and in lipolysis. And so there's actual action of TSH as a hormone itself in mitochondria, in energy breakdown, in the making of ATP, which is the major energy producing molecule in the body. And so getting that TSH in a normal range is really important when you're talking about fat loss and weight loss.
So you need some TSH for fat loss, and you need some TSH for mitochondrial function, you're saying?
Yes, you do. You need some TSH. And it's a hormone, just like every other hormone. It should be normal. It makes no sense to completely suppress a TSH or keep it high when you're trying to get all hormones, regardless of what hormone it is, in the optimal range for health.
So the story, or the trope that I hear quite a bit in the community is that, well, if you're taking thyroid medication, the TSH is doing nothing but telling your thyroid to work. And if your thyroid's not working, taking medication, there's really no purpose for TSH. There's no harm in having it low. So, yeah, could you respond to that, please?
Yeah, absolutely. So, number one, it helps with fat breakdown. It also helps with skin health. So there are TSH receptors in the skin. And so when your TSH is really low, it slows down fibroblast production, slows down collagen production. So it can definitely have long-lasting effects on skin health. And also TSH, in my opinion, is a really good indicator of how well your dosing is doing with your thyroid replacement. If your dose is optimized, if you're doing it right, your TSH should not be suppressed no matter what you're taking, whether it be, synthetic hormone, whether it be natural desiccated hormone. It doesn't matter what it is. As long as it's dosed properly, your TSH should not need to be suppressed.
So now here's her doctor's stance on that. And here's something I hear a lot. Yes, but it's how this starts out. Yes, but they were watching her T3 and T4 levels, and they were okay. In fact, they were even below where they wanted. So how could the TSH be relevant when the free hormones haven't gotten too high?
So that's a really good question, and that is a question of lab interpretation. So it depends on when she took her thyroid medicine last, when her thyroid levels were checked during the day, and in relationship to when she took the medicine. And that is pretty much the reason. So if she had her levels checked and did not take her medicine that morning, that is why her T4 and T3 are low. And if you actually had hooked her up to a 24-hour monitor throughout the whole day, you would see that there are times when her T4 and T3 are high, times when they're low, times when they're normal. And the TSH is basically your gauge to tell you that you're not doing it right.
I saw a blog post you had written in which you had mentioned about the T3 and T4 having a very different relationship with early changes in the TSH. So the TSH is logarithmically more sensitive to fluctuations. Can you make sense of that for us, please?
Yes. So TSH is an average. It tells us, how well has your thyroid been doing, just like, the gas or the electric gauge for your house. And, it's an average. So you could have been not using any electricity for a whole week because you went on vacation to Florida, but you turned on all the lights and left them on for 2 weeks at a time. And your TSH or your electricity bill will be the same as if you used an average amount of electricity every day. So it's just an average. So to put that in perspective with regard to thyroid health, if you had patient A with a TSH of 2.5, for example, and you hooked her up to a 24-hour monitor, and you found that, Monday through Sunday, her T4 and T3 looked very stable all day, every day. They fluctuated like they're supposed to throughout the day and did not change Monday to Sunday, that could be normal for her, versus patient B, who has a TSH of 2.5, and Monday, Wednesday, and Friday, her T4 and T3 are in the toilet, really, really low. And then the other days they are normal or maybe a little bit on the higher end of the range. And we do see that in clinical practice. The reason that happens is because the pituitary is trying to keep up with the thyroid producing T4 and T3. So there's fluctuations in that signal. And then also, whenever you have underlying autoimmune disease, the antibodies can make the thyroid go crazy, and you can have days where you're hyperthyroid, days where you're hypothyroid. And so in patient B, if you hooked her up to a 24-hour monitor, kept her on for a week, you would see significant fluctuations in her thyroid hormone, but the same TSH as patient A. And so you can have same TSH, but very different clinical scenarios. And that's where it's really important for your provider to actually dig in and figure out what is actually going on with your thyroid health.
And so how can someone be in a scenario in which their TSH is low, like this person, but the hormones, so you're saying that the hormones could be fluctuating like after a dosage, but not showing up in that moment?
Correct. Yeah. So if she's not dosed correctly and her thyroid medicine is peaking too much, it's causing her TSH level to be very suppressed. And then as the day goes on, who knows what's happening with her thyroid medicine. If you actually optimize her thyroid peaking and you spread her medication throughout the day like it's supposed to be done, her TSH will come back to normal.
So in other words, unless there's a lot more thought put into it, the free hormones, the T3 and T4, they won't show up at early stages of getting too much.
Yeah. So, you have to, when you're interpreting thyroid labs, looking at a full panel, really important, but it goes beyond that. It's time of day. It's when did you check your levels in relationship to your thyroid hormone? Did you actually get full absorption? Were there other medicines on board like prednisone, beta blockers, other medications that can influence thyroid hormone metabolism throughout the day and can affect TSH levels? Have you had suppressed TSH for a long time? Because in that instance, it takes a long time for the pituitary to actually start producing TSH again. So when I have patients who have had a chronically suppressed TSH for many years, I don't really get bogged down with that, although I do optimize their thyroid dosing because it typically will take them at least 6 months, if not, closer to a year to get that TSH to start budging. And that's just because the pituitary has been so suppressed, it hasn't had to make TSH in a long time. And it takes a little bit for that process to start again.
And what about the cases where someone says, but I only feel good when I take enough to where it is low? I've heard this before, and that was an argument of a past guest that I had, is that some people, many by her perspective, only feel stable or feel have their energy coming back when their TSH is well suppressed and their free hormones are on the high side of normal consistently. So what's your response to that?
So I would say I get that people want to feel good, and there's a lot of anger against this too, because people hear what I'm saying and say, oh, she just wants to reduce the dose. That's not true. So the dose, it's not, a lot of times when I'm dose adjusting people with suppressed TSH, I go up on the dose. I just dose it differently throughout the day, a little bit differently, so that it actually normalizes everything. And I would say, to patients that say, oh, I only feel good on really high doses once daily and everything like that, because I would say to them, yes, I believe that. And I do think patients need a higher dosage than some of the more classical doses are, if we're talking about like natural desiccated thyroid. It just has to be dosed properly, and it has to be dosed in such a way that the TSH can come back up into a normal range so it can have these effects for fat loss and skin health and other things. And my thought on all of this is just that a lot of times the providers are not just dosing it correctly and don't know how to dose it correctly.
So, forgive me for playing devil's advocate, but it's fun for me to be on the other side of this argument for once in my life. So, the other thing I get then is someone will say, okay, so I hear all that, but I'm feeling well. I'm not seeing any obvious harm or side effects. So why should I not just continue? I'm not, whatever reason, I'm doing okay as far as the fat loss. I see no skin symptoms. My energy is better. Why can't I just keep on doing this? It seems to be working for me in terms of my immediate symptoms.
So I would say if you actually probe into that patient, they are probably not even realizing that they may be having some side effects. And the side effects would be like energy crashing as the day goes on, for example. A lot of people call that, adrenal fatigue or adrenal crashing. If that's happening, that is a side effect in the dosing. The other thing is TSH suppression long-term, and people hear this a lot from their conventional medicine doctors. We know has data behind it to show that it can affect bone health. It can decrease bone mass long-term. So, you may not have any issues with that now, but when you're 80 years old down the road and your spine is breaking, that is a big deal. So, if we're talking about human health, lifelong human health, living with optimal thyroid levels for your whole life, then thinking about that for down the road is important. And also, TSH suppression is associated with cardiac arrhythmias. Typically, that's in older patients too. But, there are people who do say, I do have some heart racing symptoms or some palpitations. And a lot of times if somebody comes in with a really suppressed TSH for many years, they're not going to have that anymore. And that's because the body has adjusted to what they're doing by upregulating deiodinase enzymes. Those are enzymes that are responsible for thyroid hormone metabolism and trying to protect the heart from seeing too much thyroid hormone all at once. So there are mechanisms in place for that. But thinking down the line of, why do I have a TSH? Well, it's not just, to diagnose hypothyroidism with. It really is a hormone, and it has physiologic effects in the body outside of the thyroid itself. So getting it to be optimal, around 1 is normal, is really, I think, really important in doing a good job with thyroid management.
And I've seen so much data on this. There's populations that the term subclinical gets used incorrectly a lot in natural medicine. People often refer to subclinical thyroid disease. What they're talking about is a condition in which someone's not feeling well, but they have no laboratory markers of it. And that's really the opposite of subclinical. But yeah, subclinical hyperthyroidism, where someone has no obvious symptoms, normal T3 and T4, but a low TSH. We've seen data from those populations showing that they have more mortality and worse health outcomes. And then we have a lot of data from past regimes in which patients post-thyroid cancer treatment were often treated with more aggressive doses, intentionally thinking that TSH full suppression was needed. So we've seen data from that population. And I've seen many studies too looking at risk for chronic diseases, diabetes or heart disease based on TSH scores in populations. And one of the biggest ones I saw was a little over 1 million patients from, I think, last year or so. It was a UK study, and they tracked people from the electronic medical records, looking at those that were on thyroid treatment and looking at just all-cause mortality and playing that out with TSH scores. And yeah, same thing. They saw that below some thresholds and above some thresholds, there was just a big death risk factor. And that can be a tricky thing because a lot of ways in which you could be affected by some medical condition may not present in the short term. You may not feel differently because of that immediately, but it still could be affecting you down the road.
Yeah, absolutely. And I would say, this is a medicine with what we call a very narrow therapeutic index. It needs to be dosed absolutely perfectly. And I would kind of give people a reference of like blood pressure medicine, for example. That has to be dosed properly, and your blood pressure has to be perfect. If it's too high, you're at risk for stroke and, hypertensive urgency or emergency. And if it's too low, you're going to pass out. So same thing with thyroid. It has to be right perfectly in the middle, and a little tweak up and a little tweak down can make huge impacts in thyroid health, in the body's health, in downstream side effects. And I always also tell patients, we are working with imperfect tools here. So we have thyroid medicine that is available, over the or by prescription. everything that we have is not perfect. It's not like we're giving people a thyroid transplant. Even giving them natural desiccated thyroid, which has the T4 and T3, it is put into a pill form as a powder. It's packaged in a laboratory. I mean, it is not actually like taking a pig's thyroid out and eating it. So, so everything that we have is imperfect tool, but with those imperfect tools, we can really try our best to optimize thyroid levels, and we are successful in that. And when people are optimized, they feel so much better. So
you talked about eating a pig's thyroid. I was doing a lot of research for a coming book and reading tons of the history of thyroid treatment. And yeah, the earliest iterations were called thyroid feeding. And it was pretty much, what do they call a steak tartare? It was pretty much that. I think it was primarily bovine at first, but it was just ground up cow thyroid and not really processed. And people just ate that. And
have you heard about hamburger thyrotoxicosis?
Yeah, for sure. Also, sheep's head. So in the Middle East, that's happened a few times in the recent past, to where they've had sheep heads and brains that have been mixed up, and thyroid's been included in that, and people have ingested it. And I've heard about that from hamburger as well. I grew up on a farm, and not to be too graphic, but we had a common dish called head cheese, and it was cow's head. And there was a whole lot of parts that would go into that, and it was all, there would be a lot of gelatin, and then all these obscure little pieces that were kind of floating in the gelatin, and you cut this huge chunk of it, and there would be, brains and eyeballs and muscle tissue and all sorts of stuff that would be in little flecks inside this big slab of gelatin. And you'd put a huge wedge of that between some homemade bread, and then you go drive tractor all day. And that was and someone could have well gotten thyrotoxicosis from that. I don't remember the exact dissection process, but there was a lot of parts used. So that can happen. But the funny thing was those early iterations in which they were doing thyroid feeding, at first they had really no tools to see, is this a right amount? And even to be sure if treatment was needed for someone who didn't have something obvious like mixed edema coma. But then they started looking at basal metabolic rate. And it seemed that they could do a pretty good job correcting someone with various versions of just crude thyroid or different thyroid extracts. There was a lot of ones that would preceded natural desiccated thyroid, but varying thyroid extracts could be given, and they could correct someone's basal metabolic rate. But the conundrum was they were seeing really high rates of early cardiovascular death. And then in 1970, 1972, it was kind of funny. We had the Apollo program and the monumental gains that occurred in those exact years, from like 69 to 72. And that's also exactly when we got the TSH, the T3, and T4 biomarkers. And realized also when we realized that the bulk of T3 was made outside the thyroid. So then the consensus was, hey, look, now we can see that maybe we don't need to give those things that contain so much T3, and we don't need to give so much. And the benefit was, by not dosing in a way that pushed down the TSH, they by and large stopped the cardiovascular death risk. But the negative was, by not looking at changes in things like basal metabolic rate and symptomology, people weren't really getting such good benefits as they were before.
Oh, I totally agree with that. I think we probably swung too far the other way. So, giving people T4, T3, and ingesting thyroid gland, probably a little bit too much T3 in that situation. And then now, treating a lot of patients with T4 only, especially if they've had a thyroidectomy or if they've had very long-standing Hashimoto's disease and they have no gland left because the immune system's completely destroyed it. Those patients benefit so much from T3 because they're missing that 20% that the thyroid would have produced. So, we have a long way to go with regard to research on T4, T3 combination therapy. And this year at the American Thyroid Association meeting, they dedicated a whole Sunday symposium between the US and the UK and Germany on T4, T3 and all of the animal data that's coming out now about that. I have a lot of that too. We could probably talk later about that, but and just how to design clinical trials, because the problem with the clinical trials in the past with this have been that they have not been standardized, and providers don't know how to dose the medicine correctly for them to actually see results. So,
And I've also seen some trials in which they were looking at markers of serology of blood outcomes, and they were tracking some markers of patient subjective responses, but they didn't put much weight on the latter. And they said, well, this didn't make a difference because they had the same blood scores, and they ignored the fact that people had a clear difference in their symptoms. So yeah, it can be looked at more accurately.
Yeah, I mean, I always tell patients, there's not a lot of good randomized placebo-controlled double-blind trials on Hashimoto's disease. And the reason for that is in hypothyroidism, because there's not NIH funding for it. There's no funding for this. But clinical experience and patient experience means so much. And I believe it when patients come in and they tell me this is not enough or this is too much. They know what's going on with their bodies. They can probably dose the medicine themselves, just knowing how they're feeling. But with a little guidance, I think we can actually get TSH, free T4, free T3, all in the normal range. We do that every single day, and patients have really good outcomes.
We'll be right back after word from Integrative Health.
We hope you are enjoying this episode of Medical Myths, Legends, and Fairy Tales. This is Dr. Turner at Integrative Healthcare. So often we hear from our new patients that their primary care physician has told them that their thyroid and hormone levels are fine, and they should not worry. Yet the patients still have symptoms of severe fatigue, thinning hair, and weight issues. Unfortunately, this is too common with thyroid care. The good news is we can help, and there is hope. The doctors at Integrative Health, including myself, specialize in naturally treating thyroid, hormone, and adrenal issues. We would love to get you started on the path to ideal health. From the comfort of your own home, you can get treatment with one of the doctors at Integrative Health via telemedicine. Go to integrativehealthcare.com to become a new patient today. Use code PODCAST20 for 20% off your new patient visit. Again, that is integrativehealthcare.com and use code PODCAST20. Get back on the road to thriving.
And now, back for more medical myths, legends, and fairy tales. So let's talk about some options for people. So you've got a really good book out that people can come across. That's one thing. And that was actually how I think I came across you was seeing your book and reading that and really enjoying it. So what you must know about Hashimoto's disease, restoring thyroid health through traditional and complementary medicine. Wherever you get books, grab that on Amazon. I did, and really good read, and walks you through quite a bit. And you're doing clinical care as well. So you were in a more hospitalist research practice or career, but you shifted that in the recent past. Can you tell us about that?
Yeah, so I actually used to run the thyroid program at Duke University. I did my fellowship there, and I did a T32 training fellowship. So I was in the basic science lab, writing grants, writing K08 research grants for the NIH, and decided, I really loved patient care. And also research takes so long to actually get into the clinic to help people. So decided I wanted to do more clinical research and then just clinical care as well. I ended up switching over and joining Wake Forest Baptist Medical Center in Winston-Salem, where I ran their thyroid program for about 3.5 years. And we did everything from autoimmune thyroid disease to thyroid cancer, thyroid nodules, biopsies, all of that. And just listening to patients. I mean, that is the biggest thing. And I think that is where a lot of conventional medicine doctors kind of fall short. They are really busy, totally get it. I'm super busy every day too. But if you listen to patients and you ask the right questions about symptoms, you learn so much about what is going on with their thyroid medicine and how to actually redose it and optimize it to fix it. But anyway, my husband is also in medicine, and he and I love Charleston, South Carolina. So we ended up moving down here about a year ago and opened up the Charleston Thyroid Center. That's where I practice now. We see thyroid only, thyroid all day, every day, and have a lot of autoimmune thyroid patients. We do thyroid biopsies. We do thyroid cancer care. We do some minimally invasive procedures for thyroid cysts and recurrent thyroid cancer. And so here we really wanted to bridge a conventional medicine and a functional medicine approach to thyroid care. So with my patients, I talk about everything from, their symptoms and their thyroid medicine, but also integrate vitamins and nutrition and lifestyle changes and what else could be underlying why their immune system continues to be activated. So really trying to come at it from a holistic perspective. And I can't come from, a classical MD background, training in the lab, Duke University, but I would say science falls short, and even really good, really well planned out clinical research and basic science research is flawed. And so listening to patients, you're never going to go wrong with that.
Was there a point in which you were tempted to enter the dark side, or how did that all come about?
I listened to my patients and realized that what I had been taught as a fellow really was not all that there was. So I am one of those that actually doesn't like to follow like the rules very well. So I started researching myself and reading and really, piecing it together by reading everything to figure out what are patients learning and what is real and what does the data show and what's in PubMed, what actual research has been done. And then just doing this for a long time. So actually figuring out what really works with patients and how to get them better, because the thing that really messes me up and makes me cringe is when I hear people come in here and they say one of two things. I was told I had Hashimoto's disease and I just have to wait until my antibodies destroy my gland. There's nothing to do. I'm just going to have to wait till it's dead. And then I go on medicine. And I'm like, oh my gosh, what happened? and then, the other thing that people come in and tell me is my doctor says, I have hypothyroidism, I have Hashimoto's disease. I'm never going to get better. I'm always going to feel tired. And I'm like, okay, that's not true. I mean, we see people every day who get better and who come in here and they're dancing around saying, oh my gosh, I have my life back. Why did it take me 20 years to fix it? So it's just like, it's so frustrating because, knowing how to help people, now it's like, how do we help people on a more national scale? And how do we help reach people who've never been told the right things by their doctors?
Yep, that's exciting stuff. And we'll have to talk more about ways to facilitate that.
Yeah.
So we're going to get some links up in the show notes to your book, to the Charleston Thyroid Center, charlestonthyroidcenter.com. And yeah, this has been great. Thank you so much for your time.
Yeah, thank you. I appreciate the conversation. And maybe we should have a debate one day on this. That would be fun.
I'm not sure if we have a lot to debate about. I could certainly make a mock one, playing devil's advocate side, with bringing in others. Or
Yeah.
Huh. I actually, with this podcast, that was a format that I did toy with at one point, and I'd love your thoughts on this idea. I had heard some pretty big debates about nutrition. What's his name? Joe Rogan had a few on his podcast. He had Chris Kresser and Joel Kahn, both good people and dear friends. He had Gary Taubes and Stephan Guyenet. Stephan Guyenet is super bright, really good friend. And I guess I came away wondering if anyone changed their minds or if people got more deep into their own beliefs. So I don't know. I chose, like for example, for this exact topic, I did speak with someone who had a very different view from ours. And it was a tough thing because I had strong emotional reasons to think otherwise. But as I spoke and listened to her, I came to realize that, she was well-intentioned and she wanted the best for people. And from her observations and her experience, what she was saying was congruent with the facts that she saw them. And she was doing her best to provide solutions. So I did try to lead with some questions that were just about, how did you arrive at certain conclusions? And I think I did just create a bit of doubt or openness. And I never wanted to come back on and just say, oh, she was wrong about X, Y, Z. But I did then discuss myself about, here were some things that I had seen, and here were some things we have from published data. And now I have this conversation with you to go along with that as well. So yeah, I don't know. I think, and I actually heard other friends of mine push back at me and say, no, you should just talk these things through directly and have have a debate about things with those who had vested interest in the other sides, and that would be of educational value. So yeah, I've not really had a solid conclusion, but curious about your thoughts on that.
I mean, I think it would have to be very carefully constructed. I think you're right. I think people come at it from their perspective and what they've seen in the past, and that it's really helped change people's lives. And it does. I mean, some people do great. And I believe in it. I believe in all forms of thyroid medicine, but it just has to be dosed properly.
Well, and just because, and that's a pitfall, because I do also hear an idea about, like in my profession, for example, the naturopathic world, many will talk about, well, I treat patients, I don't treat lab values. And there's a noble sentiment behind that, a sentiment about almost like bucking the system and being a champion for the underdog. And those are all wonderful ideas. But the pitfall that I come across is that none of us can, we know how we feel, and we know how we feel better than anyone else does, but we don't always know what it means. And we don't always know what our chemistry, what our chemical needs are. I think about symptoms as like a warning light in a dashboard, but not like a GPS. The GPS is saying, turn right 200 yards. And the symptom is saying, hey, you're off course, right? But the symptom is not always saying which way you're off course or which way you've got to turn. So that's the tricky thing, to where in order to really respect people and really respect their short-term feelings, but also respect, be a steward for their health decades down the road, like you were talking about. Those are times to where sometimes you have to take what they're saying and honor their intention and say, well, look, here's how you're feeling, and this is not ideal. Let's change that, but let's do it in a way that's correcting your system and moving it towards a longer arc of health.
Yeah, I absolutely agree with that. And I mean, I would challenge people to say, okay, we had one side that said, we're going to just treat the lab value, but we're not looking at the patient. And we have another side that says, we're just looking at the patient, we're not treating the lab value. Can we just treat the patient and the lab value? That would be ideal, and it can be done. I'm here to tell you it can be done.
Well, yeah, and there are some lab markers that, or some ranges, for example, some differences that if someone says, hey, I feel better when my TSH is 0.8 versus 1.5, I'm like, okay, no harm.
Yeah.
But there's a point where, yeah, sometimes there can be lab values that point to risk. Other times we can say, sure, we can ignore these differences. But yeah, some differences can be red flags.
Absolutely. And I mean, it's like TSH, not one and all, not the only thing that matters. I mean, I see people all the time with very suppressed TSH levels that are actually hypothyroid and underdosed. And that's actually really common. So I totally understand why patients say, oh, I don't want to go by my TSH because my doctor's going to just lower my dosage and I'm going to feel even worse. Get it. I mean, that's true. And like I said before, usually when people's TSH are super low and they're on natural desiccated thyroid, I go up on the dose. I just dose it differently and their TSH normalizes.
So yeah, that's the main thing, is you can have your cake and eat it too. You can feel better and be safe along the way, and I'd highly encourage you to settle for nothing less. So awesome stuff. Thank you again.
Yeah, no problem. Thank you so much for having me.
All right, and those of you here with us, thanks for hanging out, and we'll see you again real soon with more medical myths, legends, and fairy tales. Dr. C back with you shortly. Hey, Dr. Christensen here. Thanks so much for joining me for another episode. Is there a topic you'd like me to cover? I'd love to hear from you. Just go to Dr. Alan Christensen on Facebook or Instagram, write your question, and use the hashtag #MedicalMyths. Did you find this show helpful? If so, please take a minute and leave us a rating on iTunes so that others can know. Thanks much, and I'll be back with you real soon. Bye-bye.